and maybe even how we as those involved in peer support can begin to change system language. So with that being said, I'll get started. I'm so happy to be here today to talk to you about peer support services to address the health and wellness needs of people living with mental health challenges. This presentation was developed by a dissemination team comprised of leaders from the Chicago Health Disparities Center at the Illinois Institute of Technology and the National Association of Peer Supporters, also known as INAPS. The Chicago Health Disparities Center is a group of investigators and persons with lived experience that examine the health and wellness needs of people with serious mental health challenges. The ultimate goal of the center is to improve the quality of health while simultaneously eliminating the effects of stigma on health conditions for persons with lived experience. INAPS is a national organization whose mission is to grow the peer support profession by promoting the inclusion of peer specialists throughout healthcare and other community systems. This presentation is based on a view of hope and recovery, and I'd like you to consider this quote by Christian Larson: "Believe in yourself and all that you are. Know that there is something inside you that is greater than any obstacle." And this is me. A little bit about my background. I am a certified peer specialist. I currently am the only employee of INAPS. I got into this profession like most of us. I didn't start out saying, I want to grow up to be a certified peer specialist, but I'm so glad I am. My first passion was actually animals, and my first career was veterinary medicine. And I was in the Air Force for 12 years before I was sidelined by diagnosis of PTSD and depression that led to many years in treatment. I was hospitalized over 70 times, mostly for suicidal ideation and attempts. I had every type of therapy offered: DBT, CBT, ACT, all of that. 47 different psych drugs over a period of about 10 years. And it was actually after I'd been in the system almost 15 years before I was introduced to peer support. And it was life-changing for me. It was the first time I had hope that I'd be anything other than a professional patient. I had accepted that this is my lot in life. This is what I deserved because I was a hopeless, helpless, worthless person. And it took peer support for me to see the difference. I actually got involved more in research in the last few years, and I met some of you on phone calls because I was involved in a study that HSRI did on Multnomah County. So I was involved in interviews with many people with lived experience for that. And I actually became interested in research after I made a transformation from merely being a recipient of services to being an active collaborator in my treatment, and then moving beyond treatment. I participate in research activities now with the VA, and that's given me a greater awareness of the research community. And I've been fortunate to share my experience and be included in planning a future research focus. I look forward to sharing this information on participatory research. I don't have anything to disclose or any conflicts of interest. And just a little, so this presentation is presenting research findings that are based on PCORI funded research in assisting people with mental health challenges in attaining their physical health and wellness goals. At the end, we're also going to discuss barriers to wider implementation of peer support. So if you haven't heard of PCORI before, it's the Patient-Centered Outcomes Research Institute. It Its mission is to help people make informed healthcare decisions and improve healthcare and delivery outcomes by producing and promoting high integrity, evidence-based information that comes from research guided by patients, caregivers, and the broader healthcare community. PCORI is a United States-based non-governmental institute that was actually created as a result of the 2010 Patient Protection and Affordable Care Act, also known as the ACA or Obamacare. Development of these presentation materials, as well as the Speakers Bureau, which I'm part of doing this presentation, is made possible by a Eugene Washington Award dissemination initiative that was proposed by the Chicago Health Disparities Center and the National Association of Peer Supporters. All materials and comments are solely the responsibility of the dissemination team and are not PCORI's responsibility. So what do I hope to achieve today? So here are the objectives. We're going to first talk about why are we concerned about the physical health and wellness of people that also have mental health challenges. We're going to go into peer support as a possible solution, and then I'll get into the research part, which is describing what community-based participatory research is, and I'll present 3 PCORI research studies that have been completed and those findings. And at the end, I hope we have this discussion on how peer support services might be implemented moving forward. And I'd like to know how things you hear today apply to you or might be useful to you. The whole idea, and one of the problems of research is it's often only published in research journals, and you need to buy that journal to see the results. Everything PCORI does is open sourced on their website. And it's really important that not only research happens, but we know what's the outcome and that we're involved in the interpretation of that. So many of you know we've shifted from what I'd call the maintenance-based model, where the best that was hoped for was to maintain a level of symptom control. And now we talk about a recovery-focused approach that emphasizes that those with mental health challenges can and do realize many of their hopes and dreams, even if symptoms persist. So it's no longer just about symptom control and getting rid of symptoms. It's about living a full life, even if you still have symptoms. And effective programs and providers embrace approaches that promote hope, and they do it by empowering connection and collaboration. People with lived experience determine for themselves what services they wish to pursue to address their goals. So why are we talking about physical health concerns of people that have mental health challenges? And as these various things pop up, you will see that we have physical health concerns that affect almost every body system. More often we hear about like cardiovascular disease and things related to that, like weight gain, high blood pressure. A lot of people have GI diseases, irritable bowel type things. We see neurologic disorders. We see more orthopedic injuries, and that's often related to people not being as stable on their feet. And has been evident very recently and still going on now, we see more communicable disease, infectious disease, and we've seen that with COVID-19, where marginalized groups are more adversely affected than the general population. And our group in particular, those with mental health conditions, concerns, have really been adversely affected, especially if they've been living in a hospital or a group home environment where the infection has been rampant and they haven't had adequate protection. So all these kinds of physical illnesses left untreated can cause negative results, quite obviously. People with mental health challenges use the emergency room more than their same-age peers for physical health problems. They often become disabled with limited mobility, along with the inability to meet personal goals related to education, work, or independent living because of physical illness. Despite the fact that state hospitals have gradually faded away because of deinstitutionalization that started many years ago, many people still end up in nursing homes, 24-hour care centers, and other places where they get the care they need that they cannot provide for themselves. And as we have heard, and there's plenty of research that says people in this group die, it's actually 10 to 25 years younger than expected. So what's the desired result? We hope to turn this around and improve the health and wellness of our community. We hope people can achieve a higher quality of life and achieve a sense of peace, serenity, and calmness. We hope to replace the feeling of inadequacy with a sense of wholeness. Wellness in this respect is not necessarily the absence of illness, but the ability to live the fullest life possible according to one's choosing. This is where I need to step back and define some things. So this titled, "What do we mean by serious mental health challenges?" Actually, officially it read, "What do we mean by serious mental illness?" I don't relate to that phrase, so I took it out. But the definition of it is here: a diagnosable mental, behavior, or emotional disorder that causes serious functional impairment that substantially interferes with or limits one or more major life activity. That's the SAMHSA definition. People with mental health diagnosis often also have substance use disorders due to alcohol or other drug use. A mental health challenge can lead to disability. Disability is facing difficulties to achieve personal goals related to education, work, independent living, relationships, or physical health. And I want to point out that this is much more encompassing than the Social Security Administration determinant of disability based solely on one's employability. So what contributes to worse health outcomes? There's several things that we'll talk in a little more detail. We know people of color with serious mental health challenges are likely to show more illness and earlier death. People who are poor often have worse health outcomes, especially if they become homeless. Crime victims get sick more often, but so does the person who commits crime, especially if they become involved in the criminal justice system. And we know that excessive use of alcohol or other drugs often worsens physical health outcomes. I'm going to discuss more in depth 6 reasons why this occurs. And the first is the general category of lifestyle. These are typically modifiable health risks or behaviors that make health outcomes worse. And by modifiable, I say they're things a person can get support to change if they choose to change them. It's not, this is what we have to make people do. People often fail to eat from healthy food groups and actually make health worse by poor diets that are high in fats, sugars, and fast foods. People not only need to know what foods are healthy, but they need to be able to access these foods. People often become sedentary, and that can worsen physical health. Supporting people to choose a way to move that is comfortable for them can be helpful. We've heard a lot about cigarette smoking, and particularly in this community. I know in all those many times I was hospitalized, people actually learned to smoke because that's how you got outside. And that's something we're left with. And smoking is a coping skill. It serves a purpose. So it's not good enough just to say smoking is bad, don't do it. We also know people practice unsafe sex that might make them more exposed to things like hepatitis B, HIV. Often sex is not discussed. I don't remember ever having a talk with my psychiatrist about sex. As peer supporters, we can have that talk. And I'm not going to go more into substances. I think we're all aware of people pick up for a reason and they have to choose to stop. I'm going to talk a little bit about the social determinants of health, and I mentioned this briefly, but often these experiences of poverty, homelessness, or being a victim of crime lead to further trauma that can worsen a person's physical and mental health. Many people with mental health challenges have limited income and are poor. Poverty at its worst results in homelessness. Many people do not have a regular place to reside or housing security. They may couch surf, live in abandoned buildings, or live on the streets, and often only use shelters when the weather is overwhelming. This group is often more often victims of crime, especially crime like robbery and assault. They also may be more likely to experience domestic violence, most typically violence and assault from a family member or a lover or friend. And this group also has more interactions with the law. Some may end up in jail or prison where they don't get any, if at all, treatment or support. The next area is what we'll generally call the fragmented healthcare system or lack of resources. Often primary care clinics that are the entry into the healthcare system may not be in the neighborhood where someone lives. Specialty care clinics are often missing altogether. Often clinics that are available cannot be easily accessed. This can be due to a lack of transportation, a lack of affordable public transportation, or inability to use public transportation. Parity insurance coverage, especially public insurance, is often lacking for needed and desirable services, so patients cannot access or pay for care. We have this thing in healthcare where I actually learned this when I worked with Multnomah County. We end up with high utilizers. And what services are available to you become available by how they see your need. And some things aren't available until you become a high utilizer. And my question is, why don't we give people access to what they need before they become a high utilizer? I never started as a high utilizer, but I became a high utilizer because I wasn't getting my needs met when I was at a lower level of care. Parity in insurance is equal pay for physical health and mental health care. Parity is often lacking, so the quality of mental health care lags behind physical care. Recovery resources are often absent altogether. There's also distrust of the healthcare system due to past negative experiences. And together, all of these make up what we call the fragmented healthcare system. The next area is the lack of culturally relevant services. Specifically, clinics often are not in ethnically diverse communities. They may lack service providers from ethnic groups that reflect the community they serve. People often want to receive care from someone that looks and talks like they do. This helps build trust in the system. Often, healthcare services fail to reflect cultural priorities, especially reflect recovery and hope as defined by that group. Recovery is not the same for us. Being able to talk about this is not the same for all of us, and we can't make it a one-size-fits-all system. I would be remiss if I didn't talk about medication effects. This slide says medication side effects. I don't use that term. All medications have effects. They have desired effects, and they have other effects which may be undesirable. Those are often referred to as side effects. They often occur at the same or greater frequency as the desired effect. So they are all effects. For example, many psychiatric drugs contribute to significant weight gain, which can lead to type 2 diabetes. This can also lead to high blood pressure or cardiovascular disease. Others cause kidney problems. People and their provider team need to work closely to address these unwanted effects and balance these with symptom reduction, always included the person's informed choice. And last is an area that honestly I don't know a lot about, but some with serious mental health challenges have genetic predisposition or a tendency to develop serious physical health illnesses such as heart problems, autoimmune disorders, and diabetes. But these cannot be overlooked. And one thing I didn't talk about was the challenge of getting physical health care when you go for physical health care, and the first thing that comes up is that you have a psychiatric diagnosis. You're often not heard, your needs are written off as anxiety, and you can have serious physical health problems, and it's a challenge to get care for them. So this isn't all doom and gloom. It's important to realize that effective treatments exist for most physical illnesses. Some are called evidence-based strategies. If you want to discuss that in the discussion, I'm glad to have a talk about evidence-based strategies. But these are those that have been proved effective through study and evaluation. It takes money and time to do those studies and for something to become evidence-based. And if a system concentrates on only doing what's evidence-based, the evidence isn't that it works for 100% of the people. It works for a percentage of the people. So if that's all we're doing nothing to help the people that didn't fit into that mold. In this country, we know that we have top quality training programs for doctors and other health care providers, and also for peer supporters or peer specialists. So there are healthcare teams that have mastered effective treatments that can help patients deal with physical illness. The problem is that many living with mental health challenges are not able to take advantage of these teams and treatments. One reason is because the perception that physical health teams are often unable to work well with people living with mental health conditions. The problem is that mental health and physical health systems are often separate. Integrated care has been proposed as one solution, one place where an individual can receive all services, physical health and mental health. There is one team that can address both mental and physical health concerns, one place for primary care, specialty care, and mental health care, and peer support should be included at all levels. Integrated care is a good idea, but not yet fully realized. One reason is there still are some healthcare providers who are resistant to it. There's primary care providers that say, I wasn't trained to work with people with mental illness. Another reason is that insurance and government programs have not fully bought into the idea or implemented the idea. They have not encouraged health providers to join together into an integrated approach. But now we're seeing some insurance companies have increasing interest in developing models that employ one single care manager to coordinate the care for a range of medical and mental health problems. So now we get to the more interesting part, which is peer support as a possible solution to this dilemma of poor health outcomes for people with mental health challenges. This is the SAMHSA definition of peer support. I think we have a few people maybe on the phone, so I'll read it. Peer support workers are people who have been successful in the recovery process, who help others experience similar situations. Through shared understanding, respect, and mutual empowerment, peer support workers help people become and stay engaged in the recovery process and reduce the likelihood of relapse. Peer support services can effectively extend the reach of the treatment beyond the clinical setting into the everyday environment of those seeking a successful, sustained recovery process. So peer support started sort of involved in self-help, you know, and classically AA and other 12-step groups are a peer support model. It was often volunteer. And there's still a group of people that hold on to this idea. If we're getting paid to do this work, that somehow jeopardizes that peer support relationship. But now we have seen peer support evolve to where there's many full and part-time employees. They have lived experience, and they focus on hope, strengths, and recovery. And if you want to discuss recovery as a word, I would be happy to do that at the end. I'm not going to go in depth on peer support, but this is more, how do we take what we do in behavioral health, having to do with mental health challenges, substance use, and relate them to physical health? There's several values that cut across all those diagnoses. We're recovery focused. We're hopeful and supportive of personal aspirations and choice. We focus on the relationship. There's not force or coercion in the relationship. We promote empowerment in life in general, and more specifically in regards to healthcare decisions. We support people to identify ways to achieve their chosen health and wellness goals. Support is often provided in the community, but can occur in any setting. There was often a belief that peer support didn't come in till someone was well on their way. You know, it didn't happen when someone was in crisis. It couldn't happen in the hospital. And we've seen that idea evolve to where we bring needed sense of hope to people at all stages, whether it's in an emergency room, in an inpatient unit, or in their home. So let me see. I think I advanced the slide too quickly, but we'll see. So one thing that I want to mention is one of our key things we do is share our story. Which is often sometimes called self-disclosure. And this story includes some of the challenges we faced. It's not a life story. And the peer supporter always can choose what to share or not. For example, many peer specialists will choose never to disclose specifics of a life trauma. I once was taught, don't disclose anything that you're not ready to have someone ask you questions about. If it's too painful for me to have you ask me questions, it's not the time for me to disclose. Second, we talk about our journey and who and what has helped us along the way. Peer supporters want to share their experience with hope and aspirations. They want to endorse the importance of empowerment and self-determination in their life. Sharing what's worked for me, or even what's worked for someone I know, can be helpful. There's also limits to disclosure. We must attend to whether disclosed information is helpful in that specific situation, or whether it is not something for that time. If we move on to what we actually do, and again, this is relating to physical wellness. Initially, this said we are involved in promote shared decision-making. I like to say we supported decision-making.
Okay,
we support the person in considering treatment options and choose those options that best meet their goals. As peer supporters, We're not involved in making decisions for everyone. It's not a shared decision, it's the person's decision. And we can support them to get the information they need to feel confident in making that decision. We might also be involved in teaching skills that provide concrete information about behaviors that help people self-manage their health and wellness goals. And third, we might actually walk a person around a complex system so they're able to access the services they want. I'll say a little bit more about supporting shared decision making. This isn't just a process for peer supporters. Everyone involved in healthcare should be practicing supported decision making. Good healthcare focuses on hope and possibilities, not poor prognosis and bad outcomes. Self-determination is key. Namely, people decide for themselves what their healthcare goals are and how they might be achieved. They desire personal empowerment so they can make informed decisions. There's a stigmatizing belief that people with mental health challenges are unable to make decisions like these. Maybe cognitive disabilities, for example, prevent them from being clear-headed and sorting out evidence for the best decision. I believe this is wrong, and peer support specialists are in the best place to challenge this. The peer supporter does not make the decision, but supports the person by helping them understand what the healthcare provider may have said by using non-clinical, everyday language. Peer supporters help a person explore all options and use a person-centered approach so the person has all the information that is needed for them to make a decision about their own healthcare. As far as supporting skills for self-management, often people lack basic information about the specifics regarding their diagnosis and regarding wellness goals and corresponding treatment options. Peer support can help people create questions to ask their providers and role-play visits with providers to empower people to be more comfortable in these situations. These questions are just examples of something you might do with someone to help them figure out what information they have and where they're lacking information that they would like. For example, what does it mean if I have type 2 diabetes, and how will it impact my future? What are all the treatment options? Are there medications? Is there surgery? Is it a hospital-based treatment? Are there lifestyle changes, or are there complementary therapies such as meditation, acupuncture, or vitamin therapies? This discussion should include everything. We support people in creating wellness goals as well as concrete ways they might be achieved. I like the World Health Organization definition of wellness, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So another thing we can do is actually help people learn about specific behaviors that might help them attain their health and wellness goals. These might include behavioral strategies such as meditation that decrease the anxiety of a specific situation. We might talk about healthy eating strategies, how we found healthy food, and how you really even decide if something is healthy or not, and if that is going to work for you. We discuss activities that a person might be interested in if they want to increase physical activity and move in a way that is beneficial in their choice. We also help them make social connections in the community of their choosing. And last, we help people locate services. We create questions and sometimes accompany people to appointments if they wish. We may go shopping with them in their neighborhood. We participate in wellness opportunities with people in their community. And the desire of this is not that they're dependent on us as peer specialists for this, but it's a way to get them involved in their community and feel confident that they can go forward without us and get connected to other supports that aren't in the healthcare system. Among many services, peer specialists help people navigate the community. We've seen problems come up with COVID-19 in the current pandemic, and it's come up before with other infectious diseases. Peer supporters play an important role. Most likely, your work went virtual. It might still be, or you might be back to doing in-person work. Peer supporters should encourage people to shelter in place when that's recommended, but peer supporters can also discuss the fears and uncertainty that come up with this and offer helpful ways to manage these feelings. We're also sensitive to how this may impact our mental health. Things that can be done is watching news together, and that can even be done virtually. So someone's not just in a room by themselves watching horrible things on the news. And I can't stress enough the necessity to talk about fear and stress and isolation. And often what we've been doing through this pandemic is physical distancing. And if we look back in our history, we were told not to isolate. That's bad for us. And yes, in fact, it is not good for us, but it's something we're forced to do. So we have to talk about ways to cope with that. So I want to take a short break here because that was a lot of information and a lot of me talking. So we'll take about 5 minutes, and when I come back, we'll talk about the research side of things, which is community-based participatory research. So I have 12:50 right now, so I'm in Boston. I forgot to tell you that. So if you're out there on the West Coast, it's 9:50 in the morning, I believe. But let's come back at 5 minutes to the hour. All right, I'm starting to see people that had gotten up come back, so I'll get started again. So we're going to talk first about community-based participatory research. And more commonly, I'll call it CBPR because it's a mouthful. It's based on the insight that programs that are developed for a specific community must include individual users of healthcare services from underrepresented groups in that community. If you're aware of things like, say, the known best treatment for heart disease is based on research that was done on middle-aged white men. We're not all middle-aged white men. So we need to involve everyone in research and find out what's best for everyone. And it might be that there's not one thing that is best for everyone, but there's things that are better for one group or another. This is where community-based participatory research can be used. And it's collaborative. We're a group of people working together, and everyone on the team has an equal voice. Everyone brings unique strengths. The group, as well as the individuals, each bring in a specific expertise. The community decides what is most important to them. And its goal is to improve the community by hearing the voice from the community. CBPR combines knowledge and action for social change to improve communities. And another goal is to eliminate disparities. By involving underrepresented groups in research projects, that helps to eliminate healthcare disparities. So one example, this was done in Chicago. It was called Inspiring Change. This was in 2015 and was done by a PCORI research grant by the Chicago Health Disparities Center. And this project was created to address healthcare obstacles by involving African Americans with mental health challenges at all stages of the research process. And they developed a workbook and a manual for this. And people with lived experience were involved in developing both the workbook and the manual. This model of CBPR and Inspiring Change identified 3 groups of people to work with community stakeholders and design the program. There were people with lived experience, there were the academic researchers, and the community advocates, which also included service providers. First among these experts are people with lived experience, people with the health condition for which specific care programs are being developed. They are people in recovery. These people should reflect the ethnic diversity of the community. Second are community advocates, or perhaps service providers, the professionals and paraprofessionals who will be charged with carrying out the newly developed program. And third are the researchers, who are the people who have a sense of the existing research literature from which ideas may be drawn for program development. The researchers also know the kind of measurement and method issues that are important to competent program development and evaluation. I'm going to go through sort of a sample of how they addressed a problem and how it involves everyone. So first, there's understanding the problem. The team might be curious, for example, why emergency room use is so high in their community. One way to answer this question might be development of a survey that can be handed out in local emergency rooms, asking users for their ideas about what the cause is. Second, the group will want to design a solution. So based on findings from understanding the problem, the team might develop a way to handle a community health program. For example, the team might come up with an idea to develop a nurse helpline to provide at-home advice that might detour an emergency room visit. The method they might use here is a survey of emergency room service providers to find out what kind of needs they have to set up this kind of helpline. And third is testing the solution. The team might develop a program evaluation project to test the newly developed program. For example, the team might ask itself, how effective is the newly developed nurse helpline in diminishing emergency room visits? This kind of evaluation might be done by counting the changes in the number of ER visits before this program and after starting the helpline. So inspiring change, this was the project they undertook. It was used in 2 studies to develop a community-based healthcare program for people of color living with serious mental health challenges. In the first project, they outlined leadership qualities that were needed for people to feel they were active participants in this. And then the second program developed leadership training to prepare people with lived experience to be full partners on the CBPR teams. The leadership training was a 2-day workshop that focused on the development of skills that people with lived experience might use in CBPR teamwork. And this list is some of the things they went over in this 2 days. It could have been communication skills, leading meetings, because in CBPR, everyone is equal. So the person with lived experience might lead the meeting. They also talked about what happens when problems arise and how do we manage conflict. And they included a section on taking care of yourself. So the last part I'm going to do a lot of talking in is on presenting 3 PCORI research studies. And this slide is probably very hard to see, but if you get a copy of the slides, even the PDF, the links in this go directly to that study, and you can read more about that study or get more information. These 5 PCORI funded studies are in fact specific to the health and wellness needs of people living with serious mental health challenges. 3 of these studies have been completed and 2 others are ongoing, and I'm going to summarize those 3 that are completed. And this is where I might use language that I don't normally use, but I can't change what they titled the study. So the first study was done by John Breck from the University of Southern California, and the title was actually a question. Can people who have experience with serious mental illness help peers manage their health care? The project tests the BRIDGE program compared to treatment as usual services. The BRIDGE program seeks to improve healthcare access, utilization, and its impact on self-confidence in managing one's own health, as well as overall health concerns. Bridge did this by having people in recovery from mental health challenges teach research participants health management skills. The Bridge program developed a manual that was used to implement the intervention. The intervention is augmented by motivational interviewing, education about illness, modeling skills, and practicing the new skills through the assistance of the peer. Bridge is a 6-month-long program. In this study, 151 people with serious mental illness were randomized to mental health care as usual, which is the control group, or the Bridge group plus mental health care as usual. Data were collected at baseline 6 months or 12 months. The measures included the number of routine visits and screenings as an indication of engagement, and participants' perception of their relationship with healthcare providers. Second, confidence in self-management was assessed by asking participants to report their sense of confidence in making decisions about their healthcare. Third, 2 sets of health concerns were looked at: chronic disease, or the degree to which research participants were concerned about ongoing and persistent physical illness, and their overall perception of bodily pain. So now in these 2 graphs, the solid orange is the Bridge group, which was peer support in addition to treatment as usual. And the control group is the other bar, which is very light dotted, and that's the control group. So findings here are reported as change scores by subtracting a person's score at baseline from their report at 6 months. So this was self-reported information. Note there was significant improvement was found in the number of routine visits and the number of routine screenings. This first graph shows change in perceived confidence in managing one's healthcare. Note the significant improvement for people in the Bridge group. The second graph shows changes in concerns about chronic disease. And the last shows bodily pain. In terms of bodily pain severity, the index is reverse scored. So actually, a negative change score means less bodily pain. Once again, we see significant improvement in perceived pain for the Bridge group compared to the control group. And this was research, and so for that purpose, all these changes were statistically significant. The second funded study was by Dr. Patrick Corrigan from the Illinois Institute of Technology, and it was titled Peer Navigator Support for Latinx Patients with Serious Mental Illness. In an effort to be fully transparent, Dr. Corrigan is the principal investigator of this award that we're highlighting, and is also the principal investigator on the overall dissemination grant that's supporting my presentation today. This study developed a peer navigator program we'll call PNP using community-based participatory research. A manual was developed to train Latinx with lived experience to become peer navigators. This manual is available in English and Spanish. In this case, peer service providers were Latinx in recovery and living with serious mental health challenges. They helped research participants to better engage in health services. In this process, research participants were expected to better address their health goals. The key element of this peer navigator program was literally to walk the service recipients around the complex and fragmented healthcare system. The program was a 12-month program that collected data at baseline 4 months, 8 months, and 12 months. There were 110 Latinx with serious mental illness and current physical health concerns randomly assigned to the PNP or to the integrated care as usual group. So integrated care as usual is the control, and the PNP group received integrated care and peer support. There were 2 sets of measures collected. First, Service engagement was assessed by counting achieved appointments each month. Second, perceived effects on health were measured on person's reported sense of recovery, empowerment, and quality of life. So it's those last three that I'm showing here in these graphs. The first graph shows a clear interaction with steady improvements in self-reported recovery for those in the PNP group compared to the control. The PNP group in all of these is the black dashed line. The second graph, or the one in the top right of your screen, is the self-empowerment, is the self-empowerment measure, and it's actually reverse scored, so lower scores represent more empowerment. Once again, there's significant interaction showing where PNP empowerment improved over the course of the study, and the control group was relatively steady. The last graph showed changes in quality of life from baseline to 12 months. Once again, there's steady and significant improvement in the PNP group, while quality of life in the control group did not really change. The last PCORI-funded study was led by Sherelle Bellamy from Yale University and called "Does a Peer-Led Program with Wellness Coaching Improve Wellness Among People with Serious Mental Illness?" Using community-based participatory research, this group developed the peer-led wellness coaching program. The PWLC was a 6-month program, included 3 months of peer-led groups, educating participants on personal wellness, stigma, and self-management strategies. In addition, program participants received 6 months of individual wellness coaching offered by a peer wellness coach. There were 74 people with serious mental illness entered into the program. Sorry for the typo. Quasi-randomization is the design that participants are not randomly assigned to different groups, but there were 37 assigned to the peer wellness coaching group. Their scores were compared to 37 others that received treatment as usual. There was data at baseline 4, 8, and 12 months. 5 sets of measures were collected, and it was all self-reported. The number of emergency room visits, participant reported changes in alcohol use. General wellness measured how participants perceived their overall wellness. And the last 2 are participant reported input into their treatment plan. And finally, self-reported satisfaction with treatment. And these are all presented in this graph, starting at the far left of your screen. It shows fewer, in this one, the solid orange is those that received peer support. And the other is the treatment as usual. So the first is that there were fewer psychiatric or substance use emergency department visits. There was greater decrease in reported alcohol use. There was greater improvements in overall general wellness. People felt they had more treatment plan input, and there was more treatment satisfaction with those that had peer support. All of these changes were statistically significant with the exception of the self-reported alcohol use, which still showed change, but it didn't meet the test of statistical significance. So now I want to move into the discussion section. And one question is, we have all this evidence. We have evidence that peer support works for behavioral health. Here's 3 studies that show evidence that peer support works for physical health. So why isn't it widely used? Why isn't it accessible for everyone? And these are some of the things that we've come up with. There needs to be a shift in practice culture. There might still be members of the existing provider team who believe peer supporters cannot be effective employees. There may be people who don't want to work with people with lived experience. Sometimes education and awareness will help peer supporters be fully integrated into a treatment team where their unique role is recognized and they're not asked to do things that are outside their role. This also requires a culture shift on the part of people receiving services. I think as a whole, we've become a group that says, I'm broken, doctor, please fix me, and it's not something I actively participate in. And we have to work to change that culture. It involves a collaboration for better health outcomes. There's also issues of identifying and selecting this workforce, training, and if there should be certification. How are people going to be supervised? And there needs to be program evaluation. And finally, we have to find a way to create fair compensation for peer service providers that will also improve their quality of life. And we might need to be real creative in how we pay for this. So I want to go to this discussion, and I'm going to go through these, and we can come back to each of those. These are just each of those things I brought up. I want to put this up here. Don't pay attention to that survey, but if Patrick Corrigan is actually in charge of this, because my presentation here is, like I said, part of this PCORI funded dissemination study, you can contact him. That's my email right now with INAPS, and I'd love to talk to any of you about this. And the other question I posed at the beginning was like, well, how does this apply to me? And some things to think about is, one, if you want to be involved in research, getting involved with a researcher that's getting money to study something, some of that money can go to you. You get involved, you tell them how you can contribute to their research in all phases, in deciding what should the question be, in what questions should people be asked, how should it be carried out, and most importantly, how should the results be interpreted? Often we see a research interpretation of one thing, and I look at it and see something completely different. So those, you know, this is is almost an opportunity where we can get more involved. So I'm going to stop share so I can see the chat. And it's going to be hard for me to catch up, but I think you can all unmute yourselves, and I'd be open while I look through the chat and try to find questions for you also to ask questions.
I have a question. I'm Julie Bennett. Wondering if, I know that this slideshow is going to become available, but I'm also wondering if you have anything handy that just has the data available.
Yeah, I mean, I have this all like in PDF. I can send you just that particular slides, and also that one slide that I showed all 5 studies. There's an active link on that. If I send you that PDF, you can actually go to the study. Okay. And then from there, go to the specific page. Like, say you want to download that Spanish Peer Navigator manual, you can go right to their page and download that manual.
So when we get the slideshow, we'll be able to do that with all of that? Okay, perfect. Thank you.
So Martha, I had a question. I understand that the PDF or the slides will be available, but what about the recording? What about there are some things that you were saying and talked about that weren't on the slide. Sorry, I want that too.
Yes, there most definitely was things I said that were not in the slides. I believe the recording's going to be available on the by Peerpocalypse.
So it's
Yes.
not just the slides, but
It's not just the slides. And if you have specific questions, please email me. I'd love to engage in discussion about this stuff.
Thank you, Martha.
I just wanted to, I'm Renelle. I just wanted to encourage people to understand that there are opportunities and paid opportunities to be peer support specialists. And when I got into this business, I never imagined that I would even be in mental health care. And then when I saw the description of the job of peer support, my jaw just about dropped to the floor, because I'm like, you got to be kidding me. You know, I can be myself and help others with mental health issues for a job, you know, and that job is hard. And sometimes we fight against the system because it is a government organization. I work for Yamhill County, and I just want to encourage people, because there are opportunities. And I don't consider myself a pay, you know, I consider myself a peer. But, you know, it takes money to live, and I get good benefits through the county. So yeah, I think there are opportunities. It's hard to dig and find them, but there are. So thank you, Martha, for highlighting that piece that we, you know, it's like, how can I got to be able to live too.
Yeah, thank you for that. And, you know, and that's so important. And often we've been asked to volunteer our services. And I'm always glad to do that, but in some ways that devalues what I have to offer. And we really need to work at this to be able to say, this is what I can offer, not this is what you want me to do. This is what I can offer. And what it's worth, and sort of by showing these outcomes, it's like, if you're working with a provider, I'm making your job easier. I'm giving you better outcomes. You know, that's fact. So, you know, if someone doubts it, and I think there was often thought, you know, what are we trying to do? Are we trying to take someone's job? You know, our expertise is not their expertise. You know, and it's emphasizing that unique role where you bring about the ability to make connection to someone that's disconnected. And a lot of these studies talk about engagement, and they measure that by the number of visits. And that's one of the things we often hear about, the benefits of peer support. It increases engagement. And people like to talk about that. There's another part that we do. And that is, if something's not working for someone, we help them disengage. And providers don't like to talk about that, but I think that's equally as important. We help someone find what's working for them. We don't help them stay in something that's not working for them. That's my personal opinion. That's not speaking for anyone but Martha.
Hi, Martha. We've been trying to do a wrap for older adults, and we have seen the work that has been done in Illinois. We tried to reach out to the researchers. We haven't heard them, but we were about to do it for a facility, and now we can't go in there because of COVID. However, they are working on getting tablets for people, and we just kind of looking around, you know, about cues or clues on how to find researchers to help get support for this, because particularly with the technical aspects, this is more complicated than it had been before.
Yes, it is. And, you know, most researchers, not all, but they're most connected to a university system. And actually, if you go to just the PCORI website, there's a lot of resources there, even about how to help you get connected. And actually what I am by doing this, I'm called a PCORI ambassador, and anyone can become a PCORI ambassador. It just means you want to be involved and you're going to help disseminate research findings. And they'll put calls out for people. Like there's one I'm just starting to get involved in. It has to do with osteoarthritis. I've had both knees replaced, and I'm interested in that study. So I'd go, if you just go to PCORI, if you just Google that and go to their website, I think there's a wealth of information there about how to be more involved. The other thing about research, I once asked, well, what's the research to actually seeing it in services pipeline? And it's like 17 years. One of PCORI's goal is to reduce that. And you get to be involved in, at least while that research is going on, it's benefiting those people involved right then. So, sometimes it's a little frustrating because, okay, yeah, that's a research outcome. That's not what's happening where I am. And, by us getting more involved, I think we can reduce that.
Yeah, because we're particularly interested too in expanding Alternatives to Violence project to the mental health facilities and and beyond. So knowing how to get research for that too would be great.
Yeah, and if people haven't heard of Alternatives to Violence project, Lauren can explain it, but that's how we met. That's a program we do in the prison system. And it's not specifically, it wasn't developed as peer support, but it is peer support.
Yes.
So if you're interested in that, contact Laurel or look up the Alternatives to Violence program. It's avpusa.org if you want to get involved in the prison. And of course, right now, we're volunteers when we do that program and we can't get into the prison. We're working here in Massachusetts. In some of our prisons, they have tablets, and we're trying to get them to let us connect that way. And so far, they don't allow us any contact directly that way. But things change. It's slow. I'm not sure if it's going to change in my lifetime, but
yeah.
I'm glad to see so many young people involved now that weren't stuck in the system for 20 years waiting to do this work.
And we also been trying to reach out, how to do it with the local police departments.
Yes.
So Lori, I have a question. So you had said towards the end of your presentation about some people, they may not, there was some people may not want to work with people of lived experience, and there were some other things that you had said. So my question would be to you, should we add specific detailed questions on, because one of the things that we do at Women's First is we have a reentry program based out of Coffee Creek Correctional Facility, and we work to serve women 6 months prior to their release. And so, excuse me. So we have a mentor request form that we send into the prisons, and we have them fill out. And then once they fill out the request form, then we do an intake with the women. And so one of the things that we're looking to also add to the intake prior to them completing the mentor request form is we wanted to set up like send in a application that kind of asks some detailed questions about what type of mentor you're looking to connect with. So one of those questions that I wanted to ask is, should we have like some specific details? Because you just said, maybe some people don't want to work with women of lived experience, or maybe, those other questions. So my question would be, should that be some recommendations of specific details on that application of just kind of so you can have like a match of what they're looking to, what type of mentor they're looking to be matched with prior to them getting connected into your program.
I think that's interesting, and I'd be curious what other people have to say. Definitely, like if someone had lived experience, whatever that might be, It doesn't mean they have to work with someone else with lived experience, but it's more like the attitude, you know, it is the attitude someone has about mental illness or substance use. It might really interfere with a mentor relationship. So in some ways, I'd say it is very important. And that brings up, you know, the huge issue. Not only do we need to educate providers about what we do in our importance, you know, the general public, and you know, we've seen this spring play out over and over. You know, they think if someone is having mental health crisis, the best thing to do is call the police. And, you know, they think, you know, the best thing to do is go to the hospital. And personally, for me, both those things have had really bad outcomes. And I'm a white woman. So, you know, we need to do much more, even just general public education about how to be with people in distress, or how to find someone that can be with them. You know, it's a huge thing. And there's even stigma or discrimination, you know, within people with lived experience. I think the way people that come from a mainly substance use background or mainly mental health background, we look at recovery very differently often. I don't say 100%. Someone put in the chat here, Roxanne, which is something we see, it's difficult for people to get into substance use treatment facilities if they have mental health issues, especially if they are taking neuroleptics or what are commonly called anti-psychotics. And it's similarly true for people to get some mental health care if they're not clean and sober. So there's discrimination even within what is lived experience. And to be honest, I used to run certified peer specialist training, and I once had someone apply that said they were really happy to work with people that had, you know, depression or a diagnosis of bipolar, but they were afraid of those schizophrenics. And I had a long talk with them about they're choosing the wrong profession if that's their attitude, and if they're open to learning to think about things differently, I'm happy to have that discussion. But it's like there's all these things, and it's, you know, and it's not anyone's fault. It's not that they're wrong. We all come with our worldview, and that's based on our experience. If that's all we've been around and all we've heard, that's what we know. And as long as people are open to that there's different ways to look at everything, you know, that's when we can really do peer support. And it's not always about having that exact experience. A dear friend of mine, who unfortunately was one of those that passed away much too young, she said to me once, you know, I haven't been in your shoes, but I've been in the shoe store. I use that all the time. I can't ever say I walked in your shoes, but boy, can I relate the feelings you're having right now.
Yeah, I believe that just, you know, it would be, I just wanted to ask to see what your feedback was, because I most definitely truly believe just working in this field in the last 3 years, it has been a really great impact on the lives of the women that we have worked with and served, because I truly, not minimizing anyone that has a degree, because most definitely degrees are good as far as having the skills and the knowledge of what that brings to the table. But people of lived experience can most definitely relate to the people in which they serve, because they have been there, they have struggled, they have that knowledge and know what it's like to be on drugs, or be in foster care, or be having that dysfunctional family, or live that trauma, or been homeless, or whatever that may be, that may look like. So whoever they're mentoring or whoever they're working with, when the situations arise, or when they're developing that relationship or making that connection, they can be able to sit down and share, whatever, after connecting with them for a period of time, they can, share their story, or they can, relate to them because they've been there before. However, anyone that have a degree, they can use the knowledge of what they learned from school, and, kind of share from that endpoint. But having both, even if they have both, that's also as well. But the relationship of having the lived experience makes a greater impact, because that you have been there where that person is coming, then you can share how you've come, how you overcame, what having that experience, what it has done for you, where it's brought you from, where you are today. You can share your story, and it makes a difference in the person's life, because they don't feel like, I'm just sitting here or I'm talking to someone that don't know what they're talking about. But it also brings hope to them, because now they're working with someone who's actually it's in a better place, and that they can gain that support and work with you on a different level. So I just wanted to ask that question, because like you said, sometimes, there could be challenges. That's why I truly believe developing trust with a person. And that's one of the reasons why we work with women 6 months prior to their release, because when you come into building relationships with people, it takes time to develop trust. So because of what they've been through in their livelihood, a lot of people have rejected them, lied to them, disrespected them, all kind of different things. So that trust it does matter. And so I just wanted to ask you what you felt about that, because it was just something I wanted to think about in that when we asked about some questions on our applications for signing up for our program. So thank you.
Yeah, and I'm not a legal expert by any means. There is a difference between asking a volunteer or even a paid person, are you willing to work with someone, versus asking them, do you have? And that's especially for a paid position, and we should all know that for our roles, they can't ask us, tell me about your disability. And you have to even be careful about that in sharing your story. I mean, I've become very vocal. I'm a person that has lived with suicidal thoughts for 28 years. I have them every day. I'm pretty functional most days. I didn't tell anybody that for years and years and years. And, part of my being able to talk about that now is I'm at a place in my life where I kind of have this idea, I can go toe to toe with you. You're not going to hurt me anymore. And I'm lucky to have that. I can get fired from a job and I still have a roof over my head and I still have food. Everybody doesn't have that privilege. And we all need to sort of assess for ourselves what brings safety for us in that situation. And it's going to be different for all of us. But I mean, I'll say, no questions asked, peer support saved my life. If I hadn't found peer support, I would be institutionalized somewhere, or I'd be dead. And that peer support came in the system. There's people that really advocate, well, we shouldn't be in that system. Unfortunately, that's where people are so often that need us. And if we're not there, they don't have that person that can offer hope by saying, I've been in the shoe store.
Quick, I don't have a question, but can you hear me?
Yes, go ahead.
Sorry. The person that spoke before you, I apologize, I didn't get your name, but I couldn't agree more with that. I think peer work is where it's at. I mean, thank you all for the work you're doing, because it's so important. And it does make a difference. But I think in the effort to educate and reduce that stigma, if you will, and teach others how effective peer work is, I think anybody with lived experience and getting a subsequent degree or already having one can go a long ways towards helping that happen, because that gives them both the personal education and experience as well as the scholastic. And I think that would go a long way towards standardizing our profession, which I think is important as well. So I know that's a little off point, sorry, but I think that would gain us a lot more, what do you want to call it? A lot more, not quality, but validation. It would validate what we do. and if we were able to standardize it. So I hope that makes
and
sense.
I think there are different kinds of peer support. There's peer support that can occur in a peer-run organization that isn't connected to any more traditional clinical support. And there's also peer support that I worked on an inpatient unit for some time. And to be honest, I was allowed to do whatever I wanted. They were so happy I was there. I could do whatever I wanted, but they weren't willing for me to suggest that they make any changes, which was hard. And to be honest, you know, every day I walked on that unit and the door closed, I had this moment where I went, oh, am I going to get out? And, you know, and I think there's a place for both. And I think there's basic things we can agree on that we do no matter what the situation is. But then there's things where it's going to look very different. If you're part of a team where you're working with providers, there's things that are different than if you're in a peer-run organization. And I think we need to be more accepting of each other that way. It's not that this way is the only way or that way is the only way. Just like there's many paths to recovery or many paths to wellness, there's basic peer support values, and then it's how it gets implemented in the moment. And there's even times where you might be asked to do something that you're really kind of questioning, this isn't something what I want to do. And I call it like drawing my line in the sand. It's like, what am I willing to do while I'm trying to make change? Versus, no, what am I absolutely not going to do? I'm absolutely an inpatient, not going to ever be involved in a restraint. Absolutely not. I'm not going to the training. I'm not doing it. But am I willing to work in an environment where they put people in restraints? Yes, while I'm trying to make change. You know, and there's examples like that. And I think for each of us, that's different. It's not this is the rules that we all follow. And a lot of people want those rules, and I don't think we can make those rules. Just like saying, you know, I don't take psych drugs anymore. I am not pill shaming people that take them. If they help, I'm all for it. If they don't help, let's find something else. And because I don't take them today, doesn't mean I've said I never, ever, ever will. We have to be able to recognize people. It's like this continuum, and it's not a straight line trajectory. It's up and down. It's up and down day to day. It's up and down throughout the day. And I think as a movement, as this recovery movement or the peer movement or the human rights movement, we all need to be more accepting and helpful of each other. Sorry, that's my soapbox.
Hey, Martha, can I have some time to mention something? This is Luke.
Certainly.
Luke A. Shooting Star. One thing that's coming out of the National Coalition for Mental Health Recovery that people might want to know about is some discussion about a major documentary that highlights the benefits of peer support and the movement Judy Chamberlain and Howie the Harp, so many people contributed to, which can bring more attention to our cause on a mainstream level, and also increase more support for the benefits of peer support. So if anybody is interested in contributing ideas to how to create such a documentary, we're in a nutshell presenting it as the idea of something similar to Temple Grandin or Crip Camp, or The Ripple Effect was also a successful production lately, but something really well produced that can highlight some of these stories where like things weren't working for me for so long with the system, and then I found peer support, and it was just like the whole tide changed, and my life started to make sense, and so much goodness happened. So that's really, really important, and I appreciate what INAPS is doing, and NCA Major R has some good stuff happening too. So join us there if you have some ideas.
Thank you so much,
Thanks.
Luke. Thank you. And we're starting to see more of those films. Some of you saw Medicating Normal. I've shown that film twice, and it will eventually be more readily available. it's in this stage where it's debuting at film festivals, so they can't make it generally available. But if you go to their website, the Medicating Normal website, they'll show all the places it's being shown. And there's some that you have to pay. There's some that they ask just for donate what you can. You know, it's being shown, you know, it was shown here next Friday or Saturday. It's shown at the Woods Hole Film Festival, which is really close to me. It's interesting because as we see more and more of those come out, and that was more specifically about withdrawal from benzos and the harm done by benzos. And actually Angela Peacock, Ange, is a really good friend of mine. You know, and you know, her story is, I took medication as directed, and you know, it ruined my life. You know, still years later, I'm dealing with that. And it's interesting because, you know, I actually moderated a discussion on that film a couple of weeks ago, and we had some providers in the audience and we had some reviews of it, and they don't dispute what is said in that, but they do bring up, well, that's not everyone's story, and this and that, and there's kind of this attempt to downplay that's going on for benzos, for SSRIs, for neuroleptics, you know, that just treatment in general, forced treatment, you know. And I think more and more it gets out, like in media like that, like this film that Luke's talking about, I think, you know, at some point we're going to reach critical mass where they have to listen to us. They can't write us off anymore. You know, there's going to be enough out there that they can't write us off. I mean, I know in my little circle, I've seen people's minds changed. And, you know, Massachusetts, in a way, is considered this pretty liberal place, but it's also got probably more medical schools per capita than anywhere in the world. And believe me, the medical model is alive and well. And so in this liberal, where we accept everyone, and you with mental illness go to the hospital, it's a real challenge. So
definitely don't want to cut off. This is such a good conversation that you all are having. I do want to do a time check. We're about 15 minutes over. We've got about 45 minutes to the keynote, so I just want to make sure everyone has a chance to grab some lunch before that. So Martha, I'll hand it back to you to just kind of facilitate that last part of it, but just wanted to touch base on
yeah, I just say, if there's anything, questions come up, or you want information or anything, please email me. I'll put my email again in the chat right now. That will be my email for a while. But if you connect with me there, I'll give you another email where you can always be connected to me. And I think the more discussions we can have like this, the more we'll do. And I'm working on getting researchers not to use such discriminating language in the title of their research studies.
Thank you so much,
Excellent.
Martha. You're
Yeah.
amazing.
Thanks, Martha. Great to be together again.
Thanks, Luke.
Thank you so much.
Thank you, Martha.
Thank you, Martha.
Have a good day, everybody.